Hi, everybody. Thanks for joining the webinar this afternoon. We very much appreciate it. And just a little bit of a background, Iowa has an agreement with the Heartland Collaborative to provide some assistance in helping state teams do some quality improvement projects around timeliness and newborn screening. So that's kind of what we're going to talk about today is how that process will be set up. Again, I'm Kim Piper, and for those who don't know me, I am the State Genetics Coordinator at the Iowa Department of Public Health. And we'll kind of introduce ourselves as we begin our part of the presentation, but I'm going to go ahead and get started. Next slide, please. Okay, I'm going to give you a little bit of background there. This is good old Ben Franklin there on the right, and a little bit of American history is that Ben Franklin was responsible for establishing a club called the Junto. And the Junto was a club for mutual improvement established in 1727 by Ben Franklin, and it was also known as the Leather Apron Club. And its purpose was to debate questions of morals, politics, natural philosophy, and to exchange knowledge of business affairs. And kind of as a side note, this was also a group that was a charitable organization who made a subscription public library available of their own books. So it's kind of one of the first public libraries that was available. Next slide, please. So based on the idea of the junta, Peter Glor, who's a researcher at MIT, coined the term COIIN, or a Collaborative Innovation Network is what that stands for. And this describes the cyber team of self-motivated people with a collective vision that innovatively collaborate by sharing ideas, information, and work, and is all enabled by technology. So a COIIN moves beyond the traditional dissemination of information, and it engages self-motivated participants from multiple settings in the full spectrum of change implementation. And some key elements of the COIIN include reliance on distance-based technology for all team activities, so similar to what we're using right now with the webinar, an expectation of rapid, ongoing communication across all levels of the team, and everyone is part of the solution on the COIIN team. And then it has a commitment to ensuring that work processes are transparent, so they're visible to everybody. And this is a picture of Peter Glor. Next slide, please. Okay, you might notice that the first COIIN that I just spoke about only has one I in it, but there are now initiatives that add an I, and the current initiative, or the Collaborative for Improvement and Innovation Network, extends the COIIN model to include the concepts of improvement. And this recognizes the need to strengthen the existing investments in maternal and infant health, as well as to develop innovative new practices. And those practices include the dissemination of information, innovation, of course, so coming up with new ideas. The idea is to achieve results faster, so this isn't like a prolonged, drawn-out process. The idea is to do the PDCA cycle, so we're looking at rapid cycles of change. We want to achieve, those results faster. We want to build leaders of quality improvement for sustainability in programming. And then obviously the bottom line is to demonstrate the effectiveness of the interventions that we do. We're going to use a virtual setting to get the whole team together, and these are the stakeholders that come together to solve the problem. And then COIIN theory is based on creating a shared learning environment, so we're all learning from each other. And this requires experts in different realms and different organizations to be members of your team. And then the idea is to improve and extend the adoption of existing knowledge to facilitate multiple learning. Next slide, please. Why do we do a COIIN? And this is from, I took this from the New Steps application request for proposals in 2014 for the first COIIN that New Steps did. And they say in order to effectively reduce mortality and morbidity, newborn screening must occur in a timely manner. Based on public comment during the September 2013 meeting of the Secretary's Advisory Committee on Heritable Disorders in Newborns and Children, or onk or dak-nack or however you want to say it, there was public comments that raised the issue of timely newborn screening. So the committee decided to review current policies and practices related to timeliness of newborn screening in the United States. And after an initial report in January of 2014, so just over 2 years ago, based on survey data, discussions, and a review of pertinent literature, the advisory committee recommended a series of time frames related to newborn screening. So the Newborn Screening Technical Assistance and Evaluation Program, or NSTEP, have worked over the past 4 years now to develop a network, collect data from newborn screening programs, and analyze quality practices within the program. So NSTEP is supporting the planning and implementation of a collaborative improvement and innovation network, or COIN, for timeliness in newborn screening. The next slide, please. So basically, the idea is improvement in the processes now, and specifically timeliness and newborn screening. So again, the COIN model facilitates an ongoing communication, collaborative learning, and innovation across the state, and adoption of quality improvement principles and practices from business and medicine to reduce newborn morbidity and mortality through improving the timeliness. Teams usually meet monthly via webinar. That's how we have done it in our state, and then some of you might be the Oklahoma and Nebraska teams that are on the New Steps 360 program as well. And they set up usually monthly meetings just to keep things going. In Iowa, we kind of meet PRN as well, especially in the beginning. We meet a little bit more frequently to just kind of lay the foundation for our project. But the meetings are supported by a contract team, which will be Heartland in Iowa. So we're available for technical assistance as this process moves forward. And then New Steps and partner organization staffers. New Steps has agreed to help us out in this process as well. There'll be an online workspace set up, and then a data dashboard to track progress towards the aims. So eventually there will be some kind of a online site that we can all go to look at what each state is doing towards their timeliness initiatives, and share best practices and ideas on there. We're all unified by a shared vision and building upon existing efforts across the nation. So states will exchange ideas, share lessons learned, best practices grounded in evidence, and new test approaches shared through the COIN. And by providing states a collaborative platform and QI tools and methods, states will be able to accelerate improvement and show measurable outcomes. I also just kind of, again, as a side note, I have been on a couple of other COIN initiatives to some extent, including an infant mortality COIN through AMSHIP, and then an adolescent and an adult health COIN through AMSHIP as well. And those were built to improve access to, and the adolescent one is to improve access to and use of well child health care visits is their focus. And I just have to say that the COIN process that New Steps has used with us in this process by far is the better process. So I appreciate it a lot when I compare it to the processes that the other COINs have used. So hopefully everybody is ready to hunker down and enjoy the ride. And right now I'm going to pass it on to Stan to talk.
Great, thank you, Kim. Yeah, this is Stan Burbrick. I am the program manager for our newborn screening here at the State Hygienic Laboratory at the University of Iowa. So I oversee our newborn screening laboratory and program here. And again, I thank everybody for participating on this call. My point was in this presentation, if you can go to the next slide, please, is basically asking a question that is there a problem? Is there really a problem? And I think most of us remember back in 2013, which was the 50th anniversary of newborn screening, at least for many of our states, we celebrated that event that year. And I know in Iowa there was a number of activities and events that celebrated the success of newborn screening expanded awareness for many people of the program, and it really was a wonderful experience that year in promoting newborn screening, its value, its successes. But at the end of that year, in November, November 16th actually, an investigative report entitled "Deadly Delays" was published in the Milwaukee Journal Sentinel. And that article, although it acknowledged the significance of newborn screening and the benefit that it had provided, it focused attention, and this obviously was known nationally, on the concern that there was harm happening to newborns as a result of delays in testing. And the implication in the article as well was that these delays that had occurred that caused harm appeared to be avoidable. And a quote taken from that article, states something that I think we all acknowledge, agree with, that the entire premise of newborn screening is to detect disorders quickly so babies can be treated early, averting death and preventing or limiting brain damage, disability, and a lifetime of costly medical care. And after making that statement of newborn screening, they went on to say that what they were able to conclude from their own investigative analysis is that, quote, one of newborn screening's most important metric, speed, was ignored for tens of thousands of babies' tests each year. And that of course, caused a great deal of concern for many of us in newborn screening, but a number also were not really sure if the information that was being presented was actually accurate or not. Next slide, please. So a continuation of it, is there a problem, is that actually prior to the publication of that article, and Kim already referred to this, is that there was an individual who made a public comment during the September 2013 meeting of the Secretary's Discretionary Advisory Committee on Heritable Diseases in Newborns and Children. And her public comment also drew attention to the issue of timeliness. And Sarah Wilkerson was actually the individual who made the public comment and shared that her son Noah died at a few days of age from undiagnosed MCAD. And she shared that upon her and her husband's kind of looking into and investigating the processes, why her son, who was screened for one of the conditions that was identified by newborn screening, why their son had died. And what they learned was that there were a number of delays that existed in the system, and urged the Secretary's Advisory Committee to create clear guidelines. And she reminded the committee, and this was her words, without proper identification of these illnesses in a timely fashion, all of the follow-up steps don't matter. And what she brought attention to is that unless we can identify these kids before the damage occurs, then everything else really has no real value. Next slide. What I wanted to emphasize at this point is that there is a problem, but that problem is not that the newborn screening programs didn't care about timeliness and so forth. What actually happened is that there was a set of conditions that the newborn screening programs were screening for that were in fact time-critical conditions, which is different than saying it's life-threatening, because there are a number of conditions that are life-threatening, but these particular conditions are there's a much shorter window in which to intervene. And in fact, in 2006, when the consensus process went forward through the coordination by ACMG, that they established a panel of disorders that was recommended to the Secretary of Health and Human Services to the advisory committee and was adopted by them, and in fact was put into place and became the federally recommended uniform screening panel, or we know it as the RUSP. So that group of experts who put together this list of disorders that should be screened for by every state, they included in their report that they published in 2006, quote, that some conditions can be life-threatening, and gave a number of examples, and can be life-threatening within a few days after birth. So it is desirable to initiate specimen processing within 24 hours of specimen receipt in the laboratory, with a 5-day turnaround time between birth and the availability of test results. And then they went on to say, it should be emphasized that detection of disease in the pre-symptomatic phase is one of the basic principles and values of screening. And so they had identified in 2006, when they put together this panel, they emphasized the fact that included among the conditions that are being recommended for screening are some who that in fact can be life-threatening within a few days. And as we know, newborn screening, as we had celebrated in 2013, began with the screening for PKU, and the time period that was beneficial to begin the interventions to start a kid on diet. There was a significant amount of time, in fact, of weeks and maybe more, where if you could get all the steps completed to where you had a child identified and you could begin the interventions within 2 weeks or so, that there was no harm that was done, that you got the full benefit. And so at that time, things like the U.S. mail was seen as an ingenious idea of how to get specimens to the laboratory for testing. Collect a specimen on a filter paper card, send it through the mail. It's reliable. It gets to the laboratory for testing. How the laboratory and the programs establish the hours of operations and so forth. that clearly a 5-day work week, not testing on the weekend, still allowed for everything to be completed, and those 2 days really made no real effect or change the benefit that could be provided to that child. But when we're looking at time-critical conditions, that context has changed, and that for those conditions, those hours and days can certainly make a difference between whether a child like Noah is identified and is able to live, or not identified and dies. Next slide, please. So as a result of the public comment that was made by Sarah Wilkerson, as well as I believe some of the energy that came from the Deadly Delays article, a work group was put together by the Secretary's Advisory Committee to actually to study this, to look at data and literature, and determine if, in fact, there could be recommendations for timeliness, and those recommendations be provided to the state screening programs. and I'll just read what the recommendations that were presented to the Secretary's Advisory Committee as a report from the work group, and was subsequently approved by the Advisory Committee and sent to the Secretary for her adoption as well. And the recommendations are to achieve the goals of timely diagnosis and treatment of screen conditions. And again, it goes back to the idea that these need to be identified pre-symptomatically in order to avoid the associated disability, morbidity, and mortality. The following timeline should be achieved by newborn screening systems for the initial newborn screening specimen. Presumptive positive results for time-critical conditions should be communicated immediately to the newborn's healthcare provider, but no later than 5 days of life. Presumptive positive results for all other conditions should be communicated to the newborn's healthcare provider as soon as possible, but no later than 5 days of life. And that all newborn screening tests should be completed within 7 days of life, with results reported to the healthcare provider as soon as possible. Next slide, please. And the recommendations went on to say that in order to achieve the above goals, initial newborn screening specimens should be collected in the appropriate time frame for the newborn's condition, but no later than 48 hours after birth. And newborn screening specimens should be received at the laboratory as soon as possible, ideally within 24 hours of collection. And so these were the timeliness recommendations that now exist that were approved by the Secretary's Advisory Committee. Next slide, please. For this COIN project and working through new steps and their technical assistance, among the things that they've been able to establish and get agreement from most of the state programs are these quality indicators. And for this project, the quality indicators that we're particularly interested in is quality indicator 5, A through D. Quality indicator 5A is time elapsed from birth to specimen collection. Quality indicator 5B, the time elapsed from the specimen collection to receipt by the laboratory. And the intent is to that receipt time is reflected by the time that sample is actually logged in to the lab. So there's actually a time stamp or a time metric associated with that event. Quality indicator 5C is a time elapsed from the specimen receipt, and again, it's using that same time of being logged in at the laboratory to reporting out of complete results. Quality indicator 5D is a time elapsed from birth to the reporting out of complete results. And again, the critical metric in this is that time between birth and when results are actually available to where action can be taken on behalf of the baby and decisions can be made. And the other time metrics are actually components of that that can be examined and opportunities for improvement. Now, we all know that there's a number of challenges and some barriers to addressing these issues of timeliness. And I'm going to turn this over to Carol Johnson for her to share with us some of the challenges of timeliness.
Thank you, Stan. And I think we all know each other, but just in case, my name is Carol Johnson, and I'm the follow-up coordinator for the Iowa Newborn Screening Program. And I'm going to talk to you on two different topics today. First, our barriers to timeliness in newborn screening, and then I'm going to talk about the benefits that the Iowa program has already recognized from our participation in the COIIN project. And a lot of what I'm going to say you already know or you already have thought of, but the first part of this conversation is just to stimulate thinking, and perhaps it's going to be presented in a way that's slightly different than you've heard it before, and maybe it'll make you think of some other things. So as you know, newborn screening is a system. This is a graphic of a newborn screening process model borrowed from New Steps that shows that newborn screening has a pre-analytical phase, an analytical phase, and a post-analytical phase. And we know that there are barriers that can occur in any of those phases, as well as overall barriers to newborn screening. Next slide, Anna. So barriers to timeliness overall. Probably the first, if you had a list of 1 through 10, I would put education on all of those lines. I think we've all done some very good education in our programs, but the reality is that it's going to have to be continuous education. We're never going to be done educating about newborn screening. And more specifically is that there still seems to be a lack of understanding of the importance of newborn screening globally, let alone an understanding of the time-critical disorders, and then the roles that people play within our newborn screening system. It isn't just lab and follow-up in the Department of Health. It's those birthing centers and all the entities within the birthing centers, meaning mother-baby units, NICUs, the laboratory, hospital administration, and you could go on and on there. And then also, besides the lab and follow-up and the health department, it's the PCPs. Do they really understand what their role is in newborn screening? And then parents also have a role in newborn screening, and they often don't hear about newborn screening unless there's something wrong. So how would we expect them to know that they have a role in newborn screening? And then we know from our COIN activity in Iowa that lack of communication and collaboration between birthing centers, at birthing centers between the mother-baby units, the NICUs, and the laboratory are a problem. And I'll tell you that if those three entities are not working well together, you're not going to be able to improve timeliness. It's imperative that those three entities work together. And then the birthing center also has to be communicating with the baby's PCP. Now, processes vary state to state, but in Iowa, the report gets mailed to the birthing center, and then the birthing center is supposed to give it to the PCP. That's not happening very timely either. And so we end up fielding a lot of calls, babies in the PCP's office for a 1-week check, and they don't have the newborn screening results. So that's another part of the process we need to work on. And then there's staff turnover, right? Which is one of the reasons I said we're going to have to keep educating and educating and educating. I had a nurse manager walk up to me at a meeting that I was at, and she'd been a nurse manager for 3 months, and she said to me, "I'm glad you're here. Nobody has told me anything about newborn screening." That's kind of scary if you think about it. So I was able to sit down, luckily, that day and spend about 30 minutes with her and kind of gave her a very, short version of what newborn screening was all about and what her role was. She was appreciative, but this experience is repeated over and over and over in every one of our states. There's no communication or passing of the baton, so to speak, to the new nurse managers, and sometimes those nurse managers don't communicate well with their staff. And that would be true for lab managers and lab staff as well. And then if you think about timeliness on a national level, there are inherent differences state to state, right? All of the states in the Heartland region do newborn screening a little bit differently. It's not right, it's not wrong, it's just different. But think about those states that routinely get a second screen. Some of those states are not testing for cystic fibrosis until that second screen comes in. So that's already about day 15, day 16 of life. Whereas perhaps you could say in a first screen state, that report would have already been released, the parents would have been notified, and that baby may have already had a sweat test by day 15 or 16 of life. Again, not commenting on if it's right or wrong, just that it's different. Next slide, please. So breaking down barriers to timeliness in these different categories, we're going to talk about some pre-analytical barriers and focus right now on barriers in birthing centers, or actually I should have said birthing center / home, because where a birth occurs can have a big impact on timeliness. A baby born at home is likely not to have a newborn screen completed as timely as a baby born in a hospital. I think we all know that and realize that. So what can we do to help with timeliness for those home births? We have babies that leave before 24 hours. Are they getting a screen, even if it's an early collection, before they leave the hospital? Or are they not coming in to get their first screen done until 2 or 3 weeks later? When the birth occurs makes a big difference too. If you have a baby that's born at 6:15 p.m. and they're eligible the next evening at 6:16 p.m., chances are you've already added another day into the system for timeliness because UPS, FedEx, and your courier has probably already been to that hospital by 6:16 p.m. And then of course it's got to dry too. So nothing that we can do about the time that a baby is born except to understand that that does impact timeliness. Some states have a consent process for either use and retention of the blood spot or even to obtain the screen in the first place. And you could imagine that that could add time to the whole newborn screening process. And then think about the collection practices at various birthing facilities. And they're very different, and they're different for their own reasons. Sometimes you hear, well, this is just the way we've always done it. We always collect it at 2 a.m. We take babies back to the nursery, do it, bring them back, and we're good. But here's food for thought. Are they collecting those screens as close to 24 hours as possible? Are they collecting them just with those routine AM labs and those routine PM labs? And based on how many babies you have to screen and and the time the card has to dry and when the courier comes, is that the most efficient way to do it? Maybe they need to change the timing of when they do the screening. Also keep in mind that NICUs can be very different environments for the newborn screening process. Either you have a very critical baby and newborn screening just is not on the top of their list of things to worry about, or in some cases, one NICU that I went and talked to their staff, they just simply, as a matter of course, didn't collect the screen until day 4 or 5 of life, because that's just what they'd always been doing. And then we also found out that some facilities were treating C-section babies differently too. Again, they really couldn't tell us why, but they weren't collecting the screens until the night before the baby went home. So that might be 72, 96 hours, after birth. And really, we all know C-section babies are no different than any other baby. They should be collected as close to 24 hours as possible. But these are just some examples of the things that we've run into. And then in hospitals, there can be a lack of staff, either in the nursery staff or the lab staff, to get screens collected every day, or there can be a lack of equipment. We went to one facility where they had 5 people working in what I'm going to call the mail out or send out area, but they only have 1 computer. And they admitted to me that there are many tests, whether it's a newborn screening card or some other reference test, that doesn't get out every day because they only have the 1 computer to work with. So these are some things to keep in mind as well. And the overall goal that we're trying to talk to them about is, please identify all the babies who are eligible to be screened on any given day. Know when your pickup for your sample is. Understand that it takes over 3 or more hours for that card to dry, and work your process backwards so that every baby that's eligible to be screened gets screened, and that their screen gets to that newborn screening lab as quickly as possible. Next slide, please. So after collection, what are some of the barriers? Batching, right? We hope this is no longer happening in any of our hospitals, but we need to be cognizant of it, and it might be. And what are the methods for getting that card to the lab? Is it a courier, UPS, FedEx? And think about, is that the most efficient way to do this? Maybe it is, and maybe it's not. Some of the states that participated in the first wave of this COIIN initiative made some changes there. In fact, I'd say most of them made some changes there. And then when does that pickup occur and how often? You would think that twice a day would be better, right? But that probably is not feasible, but is probably better. And if a pickup occurs like at 10 a.m., you could think that would be harder for them to get the screening process done than if the courier or FedEx or whatever is coming more like at 6 o'clock at night. And then we've heard nationally about some states have birthing centers that are complaining about how laborious the process is to request a pickup. So think about it from that birthing center's point of view. If it's taking them 10 minutes to get the courier scheduled to come get a sample, I don't know how compliant they're going to be, right? Who wants to be on the phone for 10 minutes? So how can you fix that? How can you make that better? And then what are your operations for your lab? So this is still pre-analytical, but let's say everything happens really well for the beginning of this process, but then the cards get to the lab, but there's nobody there to accept the cards. They sit there until the next day. Is there anybody there to ascension the sample or to start data entry? And then what if the process works well, the samples get there from across your state at 4:30 p.m., but your lab staff only works till 5. So essentially, that drop-off time is not working well, and it's adding another extra day to the process. So these are just some things to think about. Next slide, please. Still in the pre-analytical phase. So now the card is actually at the lab. How efficient is your data entry process? Is it manual or is it electronic? Does it work well? Could it be streamlined? Does it need to be fixed? And the next two things we all deal with, missing information on the card absolutely delays timeliness, right? Somebody in your program is having to make contact with somebody at that birthing center to get the information that the lab needs to run the test and to be able to verify results. That's a huge time sink in a lot of programs. And that also goes back to my very first point of education. We've got to make birthing centers understand how important that blood spot card is. Unfortunately, I forgot to put it in this presentation, but Colorado has an amazing graphic where they have this picture of this beautiful baby. And paraphrasing a little bit, it says, it's not just a form, it's a baby. When you work with this form, you hold a baby's life in your hands. I think that's the message we need to make sure that our birthing centers and our midwives and providers understand. And then moving on to poor quality samples, that's a huge, huge barrier to timeliness. How long is it taking for you to get a valid screen back in? 2 weeks, 3 weeks? Sometimes longer, right? We've all had those experiences. So again, going back to education, maybe across the country, we really need to work on reducing our poor quality rates so that babies are getting a valid screen from the very beginning. And then last but not least, what's your lab information system like? Can it even give you timeliness data? We have heard that nationwide, that there are a lot of LISs out there who can't really even give some basic QI data so people can even track their timeliness information. Next slide, please. So now we're finally to the analytical phase. What are the barriers here? Again, what time is your lab open? Do you have 1 shift, 2 shifts? Do you have one elongated shift and people stagger coming in? How many days are you open? Do you have appropriate staffing in your lab or not? And what about appropriate equipment or enough equipment in your lab? Nationally, I will tell you that I myself have probably heard 5 times, we have 2 tandem mass spec machines, but we really need 4, but we can't get them. So these are barriers to timeliness. What about your processes in your lab? Are you a homebrew lab? Are you a kit lab? Are you a combination of both? You could theorize, even though you have to do QI on any kind of reagent or assay, that homebrews might take a little bit longer. Maybe, maybe not. Not saying one's right or wrong. I'm just saying it could be a barrier to timeliness. And what are your algorithms? And going into the next 2 bullets, do you have your laboratory reporting set up or your testing set up to do your time-critical disorders first and then move on down the line to time-sensitive or life-changing disorder? We're still trying to work out appropriate phrases for the time-sensitive and life-changing, but life-changing would be like SCID, CF, hemoglobinopathy, versus time-sensitive might be PKU, something like that, versus our metabolic disorders or our endocrine disorders that truly are time-sensitive. Next slide, please. And now we've moved into post-analytical barriers to timeliness in newborn screening. And going back to the slide that Stan showed about quality indicators, there are more quality indicators. And I will tell you, after we get 5A through D tackled, we're going to be expected to tackle some of these next timeliness issues that I'm going to show on this slide. So first and foremost, how quickly is the communication of results happening? The lab to follow up to the PCP to the parents. How good is the communication between the birthing center to the PCP? Going back to making sure that they get that newborn screening report out in a timely fashion. Then do you have enough staffing in your follow-up program? And what are your follow-up staff's hours? What's the point if follow-up calls on all the abnormal results, you've got a lab working 6 or 7 days a week, but you only have follow-up working 5 days a week? There's a bit of a disconnect there. And then the next two items I'm going to combine. The bane of our existence and follow-up, I think, is not getting correct baby names and not getting correct primary care provider names. It's not unheard of to make 4, 5, 6 phone calls to get this figured out. What if you are, and this is an example that I use, what if you've got a presumptive positive MCAD on baby girl Johnson? It takes you 5 phone calls to figure out that it's Amelia Lane is really the baby's name. And when you finally get to a call Amelia Lane's provider, you find out that she's in a coma because of MCAD. These are things that we need to think about. And same thing with PCP name. You know, they often put the attending or the ordering physician, not really the name of the doctor who's actually going to take care of that baby. Stay tuned. In Iowa, we're going to try this. We're going to have a new blood spot card here shortly, and we're going to have a place where they can put ordering or attending physician, meaning like the hospitalist, just the doc who ordered the screen that day, and then a separate whole section for the baby's primary care provider. We're hoping that this will help with this issue. We're not sure. We'll keep you posted. And then going back to these other quality indicators that we're going to have to address, how quick is the referral to a specialist or to a CF center? What's the length of time to get those confirmatory testings to make a diagnosis? And then what is the length of time from a diagnosis until treatment is started? These are all things that we're going to be asked to address, and there's many things that can be barriers to timeliness in this area. So this concludes my part of the talk about barriers to timeliness. I would highly, highly encourage you, email me with any other barriers that you can think of, even if you think this only happens in your state, because New Steps is trying to compile a pretty comprehensive list of barriers to timeliness, and we need your input. So I would encourage you to send those to me. And now I'm going to talk, next slide please, Anna, about the benefits of COIIN that we've recognized within our program. So it's reestablished collaborative, and that is underlined for a very specific reason, collaborative relationships with birthing centers, midwives, and it's improved 360 communication. So what we have found is that once you let hospitals know what the newborn screening program expects and needs and why they need it, meaning a baby's life is at stake, they want to do the right thing. So instead of coming at them from, you're doing this wrong and you're too slow, approach it in a collaborative fashion. And, and then that way you get communication back too. So that's been a huge benefit for us. We've also established relationships with new stakeholders that I really don't think we had identified before, and those include risk managers. And many birthing centers have a risk manager, and we also paired up with a risk manager for an entire healthcare system that is here in Iowa, and that has been absolutely beneficial to get our timeliness message out. There's also QI officers, both in birthing centers and in healthcare organizations. And then another partner that we found was our statewide perinatal program. So our statewide perinatal program travels on a 3-year rotation to every birthing center in Iowa. They are well respected and they are listened to. So what we did is we taught our perinatal staff about newborn screening. We specifically worked with them on understanding about the timeliness issues in newborn screening. So they share their schedule with us about what hospitals they're going to month by month, and we provide them with a packet of information, including facility-specific data, so like a facility report summary, as well as specific data on their timeliness. So even if a hospital is one that we haven't gotten to talk to yet, or for whatever reason haven't participated in any of our educational activities, they hear it from the statewide perinatal program. And if it's a facility that has already been engaged with timeliness initiatives, the perinatal program reinforces our message. So that's been a wonderful partnership. It's also re-energized our educational program. So we're having our eyes opened about many things that we need to talk about. And it's also opened doors in that we've had some facilities that, we would call some, a problem facility. And we had tried to go in and do a talk and work with them, and we just couldn't get it done. But once we had this timeliness initiative, and they knew that eventually they were going to be compared with other hospitals, they're competitive, and they want to be as best as the guy down the street, right? So it opened the doors for us to come in not only to talk with them about timeliness, but also about newborn screening in general. It also made us recognize that we needed a full-time QI person in our program, and we are happy to report that Ashley Comer, that you're going to hear from in just a moment, as of March 1st, will be our first QI officer in the Iowa program. We're excited for that to happen. And then we also identified areas in our program where we just needed to pay more attention to it. So we've had this courier service 7 days a week in our program for over 10 years, but we really weren't looking at the data as closely as we should have been. We found out that some hospitals, about 4 I believe, were not using the courier on the weekends, and another handful more were not using the courier on a holiday. So again, it goes back to education. We think we've talked ad nauseum in Iowa about we're open 7 days a week, 365 days a year, but obviously not everybody got that message. And then Stan was able to work with the data, and even those hospitals that are using our courier seemingly every day, perhaps could you still use it more efficiently and effectively. And then we also have a web portal where birthing centers can go in and look up. They can do some reports and they can look up individual newborn screening results. But we found out that it really wasn't being utilized to its fullest extent. And on top of that, that not the right people really had access to the portal in some cases. If we're working with a nurse manager at a facility about timeliness and he or she does not have access to the web portal, that's a problem. And so we look to add a lot more people to our user list for our web portal and to try to make that more efficient and effective. And my goal, that I'm going to state out loud because it's a good thing to state your goals out loud, is that we eventually become a paperless state where we don't mail out any newborn screening results, that anybody, whether it's a birthing facility or PCP, logs into the web portal to get those results. Not only is it more efficient for the program, but it greatly reduces your exposure to HIPAA noncompliance, by accident. I think this is the way to go. And last but certainly not least, we've improved our timeliness, right? That's the biggest goal. Next slide, please. And the benefits of the COIN beyond our own program is that it has definitely helped birthing centers work more collaboratively in-house between mother-baby units, NICUs, and their labs. Absolutely has been a big help. Some birthing facilities have even formed their own COIN teams, which they've been wonderful to work with. They're very enthusiastic, and they're really, really making a difference. And we also have gone in when we've been talking to facilities and identified problems, such as that facility that only had one computer. By us visiting and talking about it and sharing with them how important timeliness in newborn screening was, they were able to ask for and get more computers in their lab. And so that's been helpful. And one quick shameless plug is that we have a poster for the newborn screening meeting next week that is about it goes into more depth about our experiences with our COIN project in Iowa, and I would encourage you to check that out. And now I will turn it over to Ashley Comer.
Thanks, Carol. My name is Ashley Comer, and I work at the State Hygienic Lab at the University of Iowa in the Newborn Screening Lab. Previously as a clinical lab analyst, and as Carol has alluded to, through my involvement in Iowa's COIN experience, I have transitioned into a new role focusing more on quality improvement and serving as a liaison between our newborn screening program and hospitals to provide data reports, education, and technical assistance. Next slide, please. So after today's webinar and an introduction or reemphasizing what a COIN activity is and why it can help, we're going to have a face-to-face workshop May 5th and 6th in Kansas City, Missouri through the Heartland Collaborative. And at this workshop, we can learn how to use QI tools and resources to assist with effective data collection, what to do once you have all that data, and some analysis, including the new steps quality improvement indicators, number 5, that Stan referenced, and possibly using new steps website to add your state's numbers. Here we will also learn to set some SMART goals, perform root cause analysis, do PDSA or PDCA cycles, and identify the necessary steps to complete the goal that your state has in mind, and then also recognize the support that's going to be needed to successfully achieve those goals. We want to dedicate a lot of time for small group work so folks can get together within their own state and truly work, which is why that is underlined in the workshop, on each state goal. So it's not going to be a sit and listen conference, but more of a working time. We can learn from each other from different states what's going on, and then also get back into just our own states. We'll apply some QI knowledge that we learn throughout the day and use it for our own project. Next slide. So a little bit of homework before the workshop. If each state who's going to participate could have a goal or goals in mind, they don't have to be perfect. We will work through how to set a SMART goal and go back and refine the goal during the face-to-face workshop in May. And then also just identify who's going to be on your team and what roles they are going to play in the project. So I think it's been very helpful for us in our experience not to just have what I'm going to call newborn screening partners or your state representatives from your lab and just follow up, but expanding and getting some feedback or some membership from someone in a hospital, a midwife, really incorporating opinions from the whole process of newborn screening. As we know, it can be a huge collaboration. And I think that's all the homework I'm going to give out today. And I thank everyone for staying and listening. And we can open it up for questions unless anyone else had anything they wanted to add.
I'm going to go ahead and unmute people. So if you have a question, please, this is the time to ask.
This is Joanne. Are you talking from Arkansas? Are you talking about having a go before we get to this face-to-face in May? Are you talking about us having that before we get there, or develop that when we get there?
I think it would be good if to have a jumping off point of some type of goal or area of focus, and then through the workshop we can get it to be more specific or make sure it fits a SMART goal.
Okay, thank you. I think we have that already.
Perfect.
Hello, this is Valerie in Iowa. Can you guys hear me?
Yes, and just a reminder, Valerie, if you are on, please make sure you enable your audio by entering your PIN number.
Yep, I did, 91. I enabled it.
Okay, so we can hear you fine.
Real quick, are the goals that are needed, are they supposed to be state-specific, or are we supposed to think more region-wide and think of goals for the Heartlands that we can work on as a Heartland collaborative?
This is Kim Piper. The idea is to have state-specific goals. They should be based on the needs that you see within your state. And we know that a lot of states have already worked on something similar, but they should relate to the advisory committee performance indicators and, you know, those 5 A, B, C, and D. But then be specific to your state, because only the states know what issues they really have within their own programs. And Oklahoma and Nebraska are also member states of the New Steps 360 Timeliness and Newborn Screening initiative. They've done this already. I will say that Yvonne from New Steps, and now I'm blanking on her last name, I'm sorry, she will be at the face-to-face meeting at the first part of May, and she will be helping us through the process.
There's one more question by Crystal Balmer from Nebraska. I can't, it looks like your audio is not enabled. Can you send me your chat?
No.
Anyone else has questions?
Can you hear me? This is Julie.
Oh, hi, Julie. Yes.
Just letting you know that Crystal will be emailing her question in.
Okay. Thank you, Julie.
Mm-hmm.
Do the Nebraska folks or the Oklahoma folks want to talk about what they're working on?
Go ahead, Oklahoma.
This is Lisa. Can you hear me?
Yes.
Hello, can you hear me?
Yep. Yes, Lisa, go ahead.
Okay. So for Oklahoma, we're kind of doing the same thing, trying to work on improving timeliness. Our initial focus is going to be more on improving it from the perspective of collecting a satisfactory sample at the beginning, because we have continued to have a really high unsatisfactory rate in Oklahoma despite previous educational efforts on our end. And so we've actually developed a team of our laboratory, our follow-up, the hospital association, and also some hospital members from the larger hospitals within our state. We are going to look at doing a process flow analysis that literally starts from the beginning of the newborn screening processes, from ordering the filter papers to the end, to being, for their part, would be received into our laboratory, and help them identify any barriers, as well as provide a solid foundation for education on collection of the sample, as we plan to provide the CLSI documents to all the hospitals, along with various areas in the hospital who collect the sample, whether it's a laboratory, a NICU, a nursery, or et cetera.
Sounds good.
So any questions?
Great. Okay, Nebraska's project is primarily focused on increasing the number of hospitals that have an electronic interface for the ordering and receiving of screening tests and receiving of results through automatic download. The other part of that is to improve the number of specimens that identify the not just the ordering physician, but also the post-discharge physician or the medical home. We've had that on our form for a couple of years, actually. And so we're kind of attacking that a couple of different ways, trying to get the OB providers to provide introductory information about newborn screening during the third trimester that also introduces the idea of identifying a medical home, so that when moms get to the hospital, they already know who they're going to be taking their baby to after they leave, so that they can record that. And then there'll be an educational push with the hospitals to make sure that they have processes that they are following and consistently recording the post-discharge physician on the form. And then there's another aspect to that too. With we've got some educational things we're going to be doing at Pediatric Grand Rounds on just kind of a newborn screening 101, and also a special considerations kinds of thing. And in the special considerations session, we will be able to address many of these timeliness kinds of issues. I think that's kind of it in a nutshell, isn't it? Karen or Crystal, do you want to add anything?
No, that's good.
Any questions on ours?
That just shows me again how much timeliness in newborn screening is impacted by everything before it and afterwards. I mean, it just really is the domino effect when you're talking about reaching out to OB providers to have them discuss with their patients primary care provider.
Right.
The baby once the baby's born. I mean, it's just, it goes back so far.
Yep.
Jamie in Kansas, your line is unmuted. Do you want to try?
Can you hear me now?
Yes.
Goodness, I've been trying to talk, and every time I talk, it's just a rejection.
Well, it is unmuted now, so you're good.
I promise.
I was just asking about the QA position that you guys have. Amber, is that her name?
Ashley.
Ashley. Start with an A. It's actually in the lab with helping with quality assurance issues in the lab going over to the new, does she do more than newborn screening, or, because I think that we've had a QI educator person or a QA educator person in the lab at Kansas before, and we're thinking about we would like to restart that again, but there's so many different components. I just wondered what all kinds of things she did.
Well, this is Ashley. It's kind of to be determined. It's I'll let you know in 6 months what it turns out to be. I think it's going to be an evolving position. I do work in the lab and would only focus on newborn screening. We have some plans laid out of, in terms of with our COIN project, what it came down to is I am the one who's been each month distributing the reports and working with facilities as they have more questions, because one thing we found early on is we could give them a report and immediately they're asking for more detailed information, simply saying you have this amount of percentage of specimens that were received. With our specific goal was we wanted to receive 95% of samples statewide within 60 hours of birth. So we would give them a report each month and let them know where they were standing. And immediately they were asking for more information. They wanted to know which samples weren't meeting the goal so that they could go back and look at their practices. So I think that's where we really realized that ad hoc, this wasn't going to get done. We needed to have some dedicated focus to timely respond to their requests.
And I know that, can you guys hear me again now?
Yep, yes, we can.
I just think, and maybe just when we're in person we can talk about it, but I don't know in the other states who does follow-up on unsatisfactory results when they are received in the lab, and is that something, because that's something that we do in follow-up. We don't see the specimens. We get them from Colleen and her staff, or copies of the cards so we can call the physicians. And I just wondered how that's a big issue for us, along with the timeliness issue also. But if that follow-up's done by Ashley or by who?
And in Iowa, it's a little bit of both. The lab makes the initial contact, and then after, it used to be 5 to 7 days, now after 3 days, if they haven't gotten a repeat screen in, then they quote unquote release it in the database to follow up, and then the follow-up staff take that over. But I'm sure it's different state to state. And again, there's probably no way that's right or wrong. It's just what works in that particular state. But yes, Jamie, it sounds like, I think not only in the Heartland but nationally, we've got an issue with poor quality screens that needs to be addressed.
And I think we haven't even got them drawn by 60 hours sometimes in Kansas. So you guys, yay!
Oh my God. And you'll see our goal on our poster. So our goal is that we receive 95% of the samples in our newborn screening lab by 60 hours after birth. That's our goal. That's what works for Iowa. That is not necessarily, as Piper said, you guys have to pick goals that are the most meaningful to you in your state. Because we probably have some of the similar problems, but we have different focuses and different resources, and so we're going to choose different goals.
And another thing, as Stan alluded to as well, is you're going to need to have data. So if you choose a goal that you don't have any way of measuring your progress towards meeting that goal or the objective, you might want to reconsider that. So when you look at the performance indicators for number 5, some of those, it's very hard to get data on some of those. Other ones, it's easier to find the data. So like 5A, for example, might be a little more difficult for folks to have the data for than 5B. So keep that in your mind too.
Any other questions? Comments?
Thank you, Crystal. I got your question, and I'm going to add it to the list. Do you want me to share it with everybody? I mean, I can.
You want to share it with everybody? Can you hear me? That's fine, she said.
Okay. So Crystal said to add PICUs to the list of barriers to timeliness, and I absolutely agree. And I thank you, Crystal in Nebraska, for adding that to the list. I don't know how it works exactly in Nebraska, but often in Iowa, if a baby gets discharged from the normal nursery and then becomes ill and gets readmitted, they don't get readmitted to the NICU, they get readmitted to a PICU. And we do a lot of chasing our tail and getting them to get repeat screens done and following through because, as Crystal pointed out, often they get transfused. There's all kinds of things that happen. So getting your PICUs on board along with your mother, baby, and NICUs is another very important thing. Thanks for sharing that.
This is Piper, and I almost forgot. Yvonne from New Steps sent me, they kind of have a top 10, actually 11 list of, let me see what she calls it. Timeliness top 11 suggestions from COIN Project. I don't know, Anna, if you're able to display that or if you can switch it to my screen and I can show it.
Oh, I can open it real quick.
Okay. But this is a, just kind of copying David Letterman's top 10 list. This is a list that Yvonne has compiled from suggestions that the original COIN states have provided to her. So I'll go over them quickly as soon as I'm able to do it with them. Okay, so we'll start down at the bottom of the list. You can scroll down a little bit. Well, no, we'll start at the top. I'm sorry. I guess that's how Letterman does it, as he starts with number 10. So, and you guys at the symposium next week, if any of you are going to that, you'll probably hear this as well. But number 11 is keep at it. You have to be patient and diligent. Never give up. Number 10, have a strategy. We would say that they learn that having a strategy is very helpful. There's always a better way to do it. Find out what that better way is, to paraphrase Thomas Edison. And there are many right ways to approach timeliness. Spend your time on the smart ones that will work within your paradigm. So again, that's speaking to those solutions that will be the best fit for your state. Focus on high volume providers first. And if we focus on the high volume providers, then the outcome data will change more readily. So that's kind of one of those low-hanging fruit, low-hanging easy situations. So, and then keep in mind that it's for the babies. That's the bottom line. We need changes that will affect the outcome data, but that might not affect the outcome data, but they are still the right thing to do for the babies. And don't forget maintenance. Keep climbing. When you think you're at the top, you're really not. Number 6 is talking to and learning from other states is so important. And as I think we've heard in the conversation here already, that especially, Oklahoma and Nebraska have some great things to share with what they've been working on already. So we can definitely learn from each other. And then find out what's happening in each place. And don't assume you know what happens in other departments. And investigate the current process. I was shocked to find out that our newborn screenings were sitting in the lab all day and we're not prepared for the courier who arrives at 5 p.m. So this gets back to that issue of that it's imperative to have collaboration between the nursing floors and the hospital-based labs. So we encourage that they get together and work on a solution. If you can scroll down, please.
Let me know when to stop.
Okay, I need to get down to 4, so the next page. So it helps others understand the impact of timely newborn screening on the family. And don't assume everyone knows why timeliness is important. You have to start with a why. And everybody knows that it's important, but you didn't really understand about the time-critical tests that are performed and how a matter of minutes and hours can really impact the family's life forever. Once that becomes a part of the education curriculum about newborn screening, you started seeing change happening. People can understand the reasons behind this.
I can't take it anymore.
Number 3 is remember to, hello? Oh, I didn't know if anybody had a question. Remember to include all the newborn screening partners within the state that have an impact on timeliness. And this gets back to, as we heard from Julie in Nebraska, you're even talking about your OB partners on that side as far as providing education to the families up front for that identification of a primary care provider for that baby as far as following up once that baby's discharged. So really consider when you're putting your teams together, your statewide teams together, really reach out to other champions from other areas of practice or other agencies. Look at partnering with your state designated courier service if you have one. Everybody needs to give a little and share what they're doing to conceptualize change, and make sure you have the right partners there. Number 2, education and feedback to the partners is key. You have to keep the loop closed. You have to keep circling around and providing education, double checking to make sure that everybody's on the same page. You have to be able to go back to the basics for hospital education and to impart the value of the importance of boots on the ground to this process, this whole process. Nothing can happen without those folks on the front line, if you will. And that even with an infrastructure in place, like in Iowa, we have a courier, we have 365 days a year operation and a two-shift lab. But if hospitals and providers aren't even aware of those resources are available or that infrastructure is available or how to access it, it can really hinder timely submission of specimens. And that's what we're finding is it's one thing for us to have this great infrastructure in place, but if providers don't even know about it, then, they can't use it and it won't make a difference. So then, and number 1, and Yvonne said I could leave this one off, but I'll add it on there anyway. She says that there's no way to forget to do what Yvonne asked you to do. She's relentless. And she is. She sends lots of emails and follows up on everything. So anyway, she's a good coach to have in this process. And we hope that for the Heartland COIIN process that the New Step staff and then Iowa and then even the other states that have had experience with this COIIN process will be able to help secure this as well. Thanks.
Okay. Well, anyone have any other questions or suggestions for the team? All right. Well, thank you for the presentation, Kim, Carol, Stan, and Ashley. I'm sure that everyone has your email address, and if they have questions, I'll be sending it your way. In the meantime, I'll be able to share your PowerPoint and this Word document, and we'll let you know when the recording is available for others to view. Do you have anything else to add?
Thank you.
Yes.
All right.
Thank you very great.
Everybody.
Thank you.
Bye.
Bye.